we wanted to do a survey about non-pharmacological epilepsy treatments. So obviously there's some history to this. If you look back in the past few centuries, you have people using leeches and taking blood. We still take a lot of blood today, but not using leeches. And our new non-pharmacological treatment is the ketogenic diet, shown here with the low-carb diets. But what are problems with accessing these? Are people using these effectively? Well, the Epilepsy Surgery Service did have an opinion that there's not as many referrals being made to them as there should be based upon some data from previous studies. And we thought we'd do a survey looking at this generally, considering the ketogenic diet as well. So first, I'm just going to talk about why we did a survey, and you've just heard it. Come to the results, going through each question, and a survey we sent out nationally to each of the Epilepsy12 centres in the UK, and then a briefly touch on where we're going next with this. So we distributed a survey using an electronic survey method, which you may have seen before, to all the Epilepsy12 centres in the UK. Over a month's period, had about 72 responses, and basically we asked the question, what do you feel are the barriers to making referrals to non-pharmacological treatments? Through a series of questions we'll go through next. So the first question was, do you have a formal local or regional referral pathway? And the good news was actually yes, everyone does. Essentially, one person said no pathway. So what's interesting to see is most people are referring regionally to their regional centre, their tertiary centre. A small number is referring to a local visiting paediatrician, as we know lots of people have outreach clinics that take place. And that's also good to see it's happening too. Leading on from this, this is a very busy slide, I'm afraid, but we looked at how each individual service is referred to. So how are people referring for ketogenic diet, KD, how are people referring for vagal nerve stimulator, VNS, and how are people referring for children's epilepsy surgery services, CESS. So going through one by one, obviously most people are referring to the regional team for all three of those, or discussing with the local neurologist. It's interesting to see some centres having said that no one is managing these cases independently or having an individual pathway, that actually some people were referring directly through ketogenic diet assessment or directly to a CESS centre. One centre responded saying they were referring directly to a non-CESS centre for some neurosurgical procedures, such as a vagal nerve stimulator, and again, one person had no clear pathway that they knew of. What was interesting, following on from that data, though, is we asked a question saying, specifically, can you refer to a non-CESS centre for certain procedures if you discuss with a CESS centre? And the majority didn't have access. A smaller portion had access, we were discussing with CESS centres. But some centres were referring without discussing with a CESS centre. And this is interesting in terms of the data that's available to the national CESS services, in that are there patients who maybe should be referred to CESS centres but aren't, and then if they're all been missed for a sector surgery, and equally is also a reason why the numbers are slightly lower. I'll touch on that a bit later. Next question was a fairly straightforward question, and the answer we could probably predict before asking, but basically asked, how confident are you in identifying patients who need referral? Also, we didn't expect anyone to say, I'm not confident or I'm very confident. And actually, it works out like that, with a range of 1 to 5, 1 being not very confident, 5 being very confident. People average about 4. They're fairly confident. There are a few 1s and 2s and a few 5s, but the majority are saying around 4. We moved on to ask, how many referrals did you make in the course of the year? So for ketogenic diet, most centres are making 3 or 4 referrals per year. A few exceptions making many more than that, and a fairly large number not making any. I'm not entirely sure about the validity of this data because we only had 200 cases in total being referred, and although I can't find any national data, I'm sure the figure is much higher than that from personal experience of seeing patients who seem to be referred. Especially when you compare this to epilepsy surgery, when we ask the same question, when despite every centre only reporting 1 or 2 cases, you actually find 280 cases being referred. But again, this is slightly skewed as some of the responses seem to have been directed towards people who are leading for CESS and therefore may have been a slightly higher response rate and giving higher numbers. As you can see, there are quite a few more centres referring larger number of patients. You had numbers up to 40 being the maximum number that we had an answer for. Next question is probably the one that we're most interested in, really, in terms of who are not being referred, what are the reasons for people not being referred, what are the barriers. So we listed 8 different options, including a 9th in comments. And what was good to hear is actually the least barriers that most people said were that no one had any difficulty accessing the required investigations, apparently, although I guess some people might argue with that. Following on from the question of confidence, most people said that they are able to identify suitable patients, and then most people, as we could see, had a pathway, and they weren't worried about being unclear about who to refer to. What were the biggest problems? Well, the biggest problems were these three at the top, being not able to refer independently. They also highlighted that patients and families sometimes weren't wanting to refer themselves, so both ketogenic diet and epilepsy surgery. And if you add up the responses from the second and third highest rated barriers, these actually become the most significant ones. Patients and families not wanting to be referred, which I found very interesting. In the kinds of comments we had, there are many comments saying that families found it useful being referred, even if they didn't end up having surgery, so that was a slightly surprising finding. And then, as you'd expect, lesser importance, but also still an issue of funding and cost, always the case in the NHS, and proximity to the nearest centre. We had some people reporting, particularly in the northeast of the country, who lived miles and miles away from the main care centres, and being in the northwest and Liverpool, Manchester, and central Birmingham, southwest Bristol, southeast London, and obviously the Edinburgh for Scottish patients. They found they were having to travel a long way for certain procedures to be done. So we had a bit of fun for our last question. We said, here's some cases. Please choose the ideal management strategy. And we gave them the option of not making any referral at this stage, referring for a ketogenic diet assessment, or referring for epilepsy surgery services. So again, quite a busy slide, just to make it clear. So these are the 5 cases on the side, obviously very briefly. The green boxes are the management strategies which we suggest would be appropriate in each of those cases. And actually, it turns out that each of those appropriate managements has been what people have suggested. So most people, for a focal lesion, were thinking it's appropriate to refer to epilepsy surgery. For myoclonic static epilepsy, in this case, it had failed to respond to standard treatment and identified that a ketogenic diet referral could be necessary. The third case was a bit contentious in terms we mentioned patients who had seizures with a congenital hemiplegia, but a mild hemiplegia that was rarely having seizures, and with an intral stroke, you could argue these patients should be referred to a care centre, but you could also argue maybe try some more treatment first to see how things go. Pharmacoresistant epilepsy obviously needs some referral to some more specialist. And then lastly, infantile spasms, not in this case, not responding to treatment, and clearly stating it wasn't tuberous sclerosis, it was excluded. Most people refer to a ketogenic diet assessment, which is obviously appropriate. I was interested that some people referred to a CESS centre for infantile spasms resistant to treatment before CESS. So let's just summarise our results in the last 2 minutes. So what have we found so far? Well, we've identified that the impact of a referral pathway seems to make a difference. Essentially, everyone is using a pathway, or is claiming to have a pathway. Most people having a regional pathway, it seems like they're referring to the local tertiary centre, or involving the tertiary centre neurologist, and then referring onwards. But when we come to the barriers, obviously people said that they weren't referring patients because they couldn't refer without tertiary input. And so this has meant that we are getting fewer referrals because people aren't happy to refer without discussing with the tertiary centre. So this raises the question, which we haven't covered in the survey, but what is the attitude of neurologists working in tertiary centres about the non-drug treatments? Are they, do they have availability of ketogenic diet services or ability to refer to care centres, or are they happy to refer patients? Or are they tending to refer patients for more medical therapy first? So there's something there that we need to look at a bit further. Geography, not so clear from the results we've seen there, but from the comments we had about proximity of hospitals to regional centres of these treatments is obviously an issue, particularly for children's epilepsy surgery services, as I touched on earlier. But also regionally, some regions like East Anglia, where I'm working, are quite large, and therefore patients might be having to travel a long way to the nearest regional centre. It was interesting to see that some people refer to non-care centre for vagal nerve stimulation insertion. As I mentioned, this assumes they may not be suitable for a surgery, and therefore they could be missing on having this. It might mean there might be cases that are missed, essentially. And the last point, which I think is really interesting, actually, that patients don't always want to pursue ketogenic diet epilepsy surgery. And also I can kind of imagine reasons for this, but we haven't formally looked into this, and it would be really interesting to see what the views are of the children and young people and families while they don't want to be referred. And these are the things probably that we're going to move on to next to consider when we take this work next. But obviously, as well as those points are raised, generally raising the profile of children's epilepsy surgery services is something that probably we need to do further. And it's interesting, there are very good resources on the internet, different centres about who to refer, why to refer, different things like that, to the criteria to refer. But it seems that people aren't always fully happy in interpreting those. And obviously, this is the starting point today. We're raising awareness of this issue, and that's really where we want to take things next.